bisection of the gastroc is, and the moving arm, again, is just gonna be that midpoint of your calcaneus. Again, kind of like your plantar flexion, dorsiflexion, you wanna do a little, and you're gonna stabilize at the distal ankle. I don't know. Aren't you supposed to be my like cinematographer person?
Or the overhead cams?
Oh, yeah.
What's the axis again?
Axis is midpoint of your posterior medial lateral malleolus on the Achilles.
Point of posterior.
So here, she kind of has a little red mark. That's going to be helpful. What was I saying? Oh, 0. So what you're going to do, you can wiggle a little bit of inversion, eversion. Oh, I'm going to raise you up a little. Inversion, eversion to make sure they have that 0. Because again, what we were talking about is you're measuring the total available amount of inversion, eversion motion. So even though she might start in a few degrees of calcaneal inversion, what I'm measuring is that total range of motion. So as long as she can get to 0, my starting range of motion measurement is going to be 0. Does that make sense? Because I know there were some questions saying like, well, the foot's starting in 10 degrees of plantar flexion, so do I write it as 10 to 50? If they can get to 0, you're measuring the total available amount. So you want to see if they can get to that 0. The other thing, your line of force and your motion of force, you're going to be using that web space underneath the calcaneus, using your elbow torque to kind of do an angular cupping motion into eversion, inversion. Okay? So I'm gonna just do a little bit of a wiggle. She's definitely lacking more eversion. She's getting more inversion. I think AAOS says 5 degrees in each direction. What we learned was it's a 2-to-1 ratio of 2 degrees of inversion for every 1 degree of eversion. What would you?
The 2-to-1.
So it's 2-to-1. So normal is for every 2 degrees of inversion, I'm gonna have 1 degree of eversion. So if I'm getting 10 degrees of calcaneal inversion, I should have about 5 of eversion. Does that make sense as well? Eversion is gonna be more likely a hard end feel, but it can be firm. Again, kind of patient specific. Inversion is going to be firm. And this is another one where you can line up your goni and leave it and move the goni with the calcaneus as you're moving it. So first I'm gonna do, she's lined up. She sits in a little bit of inversion, so I'm just gonna line her up a little bit, cupping that calcaneus, and I'm bringing her, oh God, I don't like these close-ups, out.
So you're barely eating.
And I'm getting 16 degrees of eversion, and then if I'm cupping and bringing her in, any pain? I'm getting 30 of inversion, sorry.
You weren't wrong with the 2-to-1.
15.
So it really is. Pain or discomfort there?
Your fulcrum is on
So where medial lateral malleolus,
the, they meet.
where they meet, bisect in the middle,
Okay.
along that mid-calf, and again along that midpoint of the calcaneus. And what I was saying is she sits naturally in just a little bit of calcaneal inversion, but I can move her into eversion, so I know her she has a 0.
She has 0. She just sits.
So does that make sense?
Tight, yeah.
So, but when I bring her over, I can bring her over and hold her in that 0, and then move into that 15, 16 degrees.
Do most people tend to have like a starting inversion or eversion?
It depends. Sometimes if people have like really high arches, it might be more inversion. If people are really plespanus or flat-footed, they might start a little more eversion. It really depends. Some people will have completely straight up and down Achilles. Sometimes you'll see some like valgus or varus bowing, but you do want to make sure that they look like each other. So that's normal for them as long as one's not like completely bowing out this way and one's straight up and down, then that would probably tell you something might be a little bit off. You're just looking for symmetry. Questions on those? Okay, can I have you lay on your back, please? Foot off. Go up this way just a little bit. We're just gonna do toe. So actually, let me do this foot, sorry. Okay. So the last one we're gonna look at is great first MTP flexion extension. We're not gonna get you to get like teeny tiny gonies doing all of your IPs of your 2nd through 5th meds. But we are gonna do first MTP extension and flexion. Are we doing first MTP IP as well, or first
Just
MTP flexion?
Just MTP.
Okay, so we're only gonna ask you for MTP flexion extension. Your axis is gonna be, and again, I would be on this side looking, but I'm just showing you for now. Your axis is gonna be that MTP joint. Your stationary arm is gonna be along that first metatarsal. Moving arm is gonna be along that proximal phalanx. You should be getting about 75 degrees of MTP extension. And why would you want so much MTP extension? Why is that important? For gait when you're doing that toe off. So that's actually a really common cause of foot pain or even knee pain, is if your patient's stuck and only getting like 20 or 30 degrees of that MTP extension. That's something you're really gonna wanna work on. So 75 for MTP extension, 45 for flexion, 45?
30.
30. 30 for flexion. So the one thing I would note is you're gonna stabilize that distal end of your first MTP, or first metatarsal. I prefer to push on those lateral borders of proximal phalanx so that I'm not pinching and blocking those ligaments, so that that's not a potential reason for limited mobility. So I'll pull on the sides and come down. So firm end feels for both. I'm gonna come and look, and I'm sure my big fat head is blocking. She looks like she has, I'll say 80. My big fat head gonna block all of this. So I'll preset my goni for 80. And you can also use the smaller one. This one's not bad because it has the it has the rounded edges, but the smaller goni is also good for MTP. So come back here. Very sorry. And again, your line is parallel to that proximal phalanx. You should actually be able to keep it pretty close. And she looks like she has about 80 or 78, excuse me, 78 degrees of MTP extension. And then same for the flexion. Bring her down, firm end feel. She looks like she has that 30, so I'll preset my goni for the 30. Hold on. Any pain? Nope. She's at 44.
I had to.
That was closer this time.
I mean, I'm so glad you guys are gonna look at the pores. Anything up there?
Get up a little in there.
Questions, comments, concerns?
Remember, the more you mess with us, the more we mess with you.
I was literally trying to get the shot.
Sorry, actual question. Shh. That one's fine. Yep.
I was just wondering, I thought that was like a nice little pearl saying that the knee pain could come from not having enough extension
Oh, yeah.
of the toe. How would that work with like the chain reaction?
So if you're not getting full great toe extension, it could cause either like excessive knee hyperextension because you're having to get that push off from somewhere, where you're then going to cause some more ligament damage up at the knee. I've even heard crazy theories of how shoulder pain can be a cause of limited toe extension, like if you're a throwing athlete, because if you're not getting the great toe extension that you need, then you're going to have to do extra wind up and something from the shoulder.
Wow, that's pretty cool.
That makes sense. Oh, for the.
It actually,
That makes
if you ever
sense.
heard of, did you ever do a Gary Gray course? Grade 3? There's people that have talking about like fascial systems and ligament systems and how the whole chain, it's called a chain reaction. Your whole body system is connected. So in a throwing athlete, if you're limited
That makes sense
down
in the
here,
biomechanics, though.
you're having to, it actually does.
Yeah.
It's crazy if I say like, yeah, your great toe's messed up, so your shoulder's messed up. And you're like, I'm sorry, what? But yeah.
So from what I know from like the fascial system connection, There's a book called Anatomy Traits. So there are a lot of subsections of like paths that like the fascial system goes, but fascial system, one connective system throughout the whole body. And then obviously there's thickenings of your fascia. So plantar fascia, IT band, thoracolumbar fascia are like the three main big thickenings. And those are all common areas that people have pain issues that we see them for. So the track that is the easiest one to explain to someone how it's all connected is the plantar fascia kind of follows up through like the calf, crosses over to the IT band, which goes up into the hip and then crosses over through the thoracolumbar fascia and kind of follows lat up to the opposite shoulder. So you, based on that theory, you could work on someone's right foot, and that could affect left shoulder pain. The stuff that we're talking about with the range of motion in the great toe affecting the knee, affecting the shoulder would be more of a biomechanical thing, which may or may not be affected. The other thing that I would think of with like limited great toe extension is as you're kind of going through that push off, not necessarily hyperextending, but just as you're coming over the great toe, that would increase force of like the tibia pushing up into the knee joint would be another possible. So again, it depends what the individual is doing to compensate. The hyperextension would be as they're coming through and they're not able to get there, then if the tibia kicked back. So those are both things that you could see. It just depends
If there's like a muscle
on what the individual is doing.
Excuse me.
And then sometimes what will happen is people will get excessive great toe extension. A lot of people, as we noticed, have tight ankles, the dorsiflexion. And over time, if they go into either too much extension or if they don't gain that extension, but that force is going through the great toe, what is it called when
The windlass is that?
no, so the great toe can actually start to
Oh, bunion.
bunion.
Yeah.
So it will kind of adduct and it will create a moment with the first metatarsal where the first metatarsal is abducted and the great toe is adducted, and then it's a bunion, which seems just like a big bump. That prominence on the head of the first met may actually get bigger, but it might actually just be from the angle of that joint changing due to lack of dorsiflexion and increased pressure at that joint.
Yep.
A lot of women have it from wearing tight shoes.
A lot of
A lot of men have it too.
Yes.
I do not.
Does the bone, like, just
You don't wear heels all the time? Pointed
Sometimes.
toes?
I don't, for the bone, I wouldn't say the bone grows, it would be more like a bone spur in addition to the angle of the joint changing. Yeah, so a bone spur is like extra calcium deposit, usually in areas of increased stress. So like the calcaneus on the bottom where the plantar fascia attaches, or kind of what I was talking about where if there's too much tension going through the Achilles on the back of the heel, you can get bone spurs around either of those areas.
My mom had that. She had surgery on it like 5 years ago.
Bunion?
Love to do surgeries.
She has to